So today we have Dr. Yacob Tedla. Uh, he's an assistant professor of medicine. He earned his PhD from the Division of Epidemiology in the Department of Medicine at Wisconsin University or University of Wisconsin. And he did his postdoctoral fellowship in cardiovascular disease in epidemiology at Northwestern University from 2017 to 2020. And then ever since, he's been at the Department of Medicine at Vanderbilt University. Dr. Tedla's research interest focuses on vascular, structural, and functional abnormalities and their effect on cardiovascular events. He's currently funded by the NIH KO1 to evaluate provider compliance to hypertension treatment guidelines and patients' blood pressure trajectory. And he'll be talking a little bit about that today. He has worked with several collaborators here at UAB and specifically in our department with the faculty group in Cardia. So with that, Dr. Tedla, welcome to the EPI seminar and over to you.
Thank you so much, Sadib. And I was told to talk a little bit about my career trajectory just briefly. After completing my postdoc while I was at Northwestern back in 2018, I received the KO1 Career Development Award grant focusing on this topic that I'm going to present today. A year after I received the grant, I received a tenure track position at Vanderbilt, which I transferred there. I've been at Vanderbilt for about 5 years now. And currently we have received a supplementary grant RO1 to this one, trying to see the difference by race, ethnicity, and geography as well. You've described my research interest, so I think briefly that's what my trajectory looks like. Today I'm going to discuss using target trial emulation, trying to understand provider adherence to the current hypertension treatment guideline, specifically the 2017 and 2025 guideline, because they are very similar, and how provider adherence to the guideline relates to prospective patient blood pressure control. Is my voice okay? Can you hear me well?
Yes, that's fine.
Okay, great. I would like to acknowledge people who had been involved as mentors on this K1 award when I was at Northwestern University as well as at Vanderbilt. I would like to acknowledge also experts who have been involved on these projects when we're trying to develop and validate a measurement tool that we think would help us to evaluate whether or not a provider was treating a patient according to the guideline. And I'd like to acknowledge the NHLBI as well. According to the current definition of hypertension, which is a blood pressure of greater or equal to 130 over 80 millimeter of mercury, about 48% of US adults aged 20 and above have hypertension. And rate of control of blood pressure, defined as blood pressure less than 130 over 80, is very poor, 22.5. If you look at the picture on the right, among the 48% US adults with hypertension, close to 80% of them has been recommended lifestyle and medication. And the other close to 21% recommended only lifestyle. And among all those together, 77.5% have uncontrolled when uncontrolled blood pressure is defined less than 130 over 80. Among those that has been recommended medication in addition to lifestyle, actually close to 57% of them has uncontrolled blood pressure. And if we look into those with uncontrolled blood pressure, it's not because they are untreated that have uncontrolled blood pressure. In fact, close to 50%, 48.8% of them are treated. And even among the treated, if you look it further on stage 2 hypertension or blood pressure greater or equal to 140 over 90, 56.8% of them have that high blood pressure or uncontrolled blood pressure above 140 over 90. And it's expected that the prevalence of hypertension would increase by 7.2% by 2030, and the cost to reach as high as 200 billion. It's well known fact that hypertension doubles the risk of cardiovascular disease and other disease events, but with optimal blood pressure control, up to 50% of cardiovascular disease could be prevented. One of the motive for developing this project back in 2018 was the trend that we were observing in the decline in the blood pressure control rate back then in the United States. Historically, blood pressure control was increasing steadily from the year 2000 up to the year 2010. It was somewhere around 32% in the year 2000 and reached as high as 52.8% in the year 2010. By the way, blood pressure control here is defined as less than 140/90. So we were seeing a steady increase from 2000 all the way up to 2010. But since 2010, there was a gradual decline from 52% somewhere around 2010 to 51% somewhere around 2015, and then 48% around 2020. Of course, after 2020, it's bouncing back and showing a bit increase, getting back to 51%. But when we were developing this project back then, there was a gradual decline in blood pressure. And during that same time period, between 2010 to 2020, there was decline in treatment by 4.6%, and treatment effectiveness, which was defined as those treated and achieved blood pressure control, that also decreased by 6%, while access to care, which is shown on the lower two graphs, access to care remained the same, and monotherapy, in fact, increased by 4.2%. In spite of those, there was a decline in treatment effectiveness, decline in blood pressure control as well. And there was suggestion in the literature back then that this decline in blood pressure is due to high therapeutic inertia. And we were trying to see if that was the case in this project. At the same time, there were new insights that we found was helpful in understanding the determinants of blood pressure control in hypertensive patients back then when we were developing this project. Earlier studies were emphasizing too much on lack of insurance, lack of having regular provider, or higher susceptibility to hypertension, like individual susceptibility to hypertension such as age, obesity, or non-adherence to medication as determining factors. However, enhanced studies and others have in fact showed among those with uncontrolled blood pressure, 92% of them have insurance and 86% have regular provider, indicating that lack of access to a provider or healthcare setting and insurance may not be the major determinant factors. In addition to that, major trials such as the CONVINCE or the MAP trial has showed that with strict protocol adherence and following strictly to the protocol, blood pressure control could reach as high as 90% or 85%. In comparison, during routine clinical practice, blood pressure control, which was defined in those studies as less than 140/90, was between 62 to 64%. So what this is telling is that if you strictly follow a protocol, blood pressure control could reach as high as 90 actually, which was not the case in routine clinical practice setting. And other studies and survey studies has also showed that therapy was intensified only in 22 to 40% of patients with uncontrolled blood pressure who were eligible for intensification, and about 43% of providers in fact waited for systolic blood pressure to reach as high as 160 and above to start medication intensification or medication adjustment. So collectively, all this story in this slide and the previous slide that I showed you was pointing out to quality of hypertension treatment, which was the motive for this project. Yes, so quality of treatment could be a key determining factor. So in addition to trying to investigate quality of hypertension care by assessing provider adherence to the current hypertension treatment guideline we had at the time, we were also trying to do this project in a way that address limitation of previous studies. So previous studies on compliance to hypertension treatment guideline use majority of them subjective assessment, such as provider self-report, And this leads to social desirability bias. Providers are likely to respond in a way considered appropriate and acceptable if self-report is used. So we were trying to use, may not be an objective, but at least what has been recorded or what they have done actually in the AHR as non-self-report measure of provider treatment practices. And most previous studies failed to evaluate multiple aspects of hypertension care. Most of them focused on looking rate of prescription of certain medication class by year and how that changed, and that doesn't really tell whether a provider adhered to the guideline or not. And in addition to that, most of the studies did not study, in fact, whether or not the provider were followed according to the guideline. And very few studies take into account comorbid conditions, because hypertension treatment differs depending on whether you have other comorbid conditions such as diabetes, CKD, or other cardiovascular outcomes. So we're trying to bring all this together by incorporating lifestyle, comorbid conditions, follow-up, laboratory assessment, and we even collect data on drug side effect and contraindications, because for a valid reason, a provider could deviate from the guideline if there were drug side effect or contraindications. So in view of those limitations, conclusions of previous studies were incomplete, so we're trying to address that at the same time. So the objective of the project was to address limitations of previous studies and assess provider adherence to multiple aspects of hypertension management guidelines, from blood pressure level, medication, taking into account comorbid conditions, and taking into account follow-up visits as well. And then to investigate the association between adherence to the guideline and prospective patient blood pressure trajectory, as well as see how this adherence changes over time as well. So the specific aim one was focusing, developing and validating a measurement tool to help us assess compliance to those different aspects of hypertension treatment guidelines. Because there wasn't a measurement available at that time, we decided to develop and then to do some validation study to make sure it's an acceptable measure of adherence. And the second aim was to use that developed measurement tool to investigate degree of provider adherence to the different component of the guidelines, as well as to see trend over time. And the third aim was to examine the association between provider level of compliance to the guideline and patient blood pressure control. This is what the 2017 guideline, which is the same with the 2025 guideline that existed back then when we were working on this project. I will focus only on the right side of this project, which is the stage 1 and stage 2 hypertension. The guideline says if a patient has stage 1 hypertension, the guideline says assess if they have clinical cardiovascular disease, diabetes, or CKD, or if their 10-year atherosclerotic cardiovascular disease is greater than 10%. If that is no, only lifestyle is recommended, and the guideline recommends reassessment within 3 to 6 months. But if there was a clinical cardiovascular disease event, CKD, diabetes, or their 10-year atherosclerotic cardiovascular disease risk score is greater than 10%, the guideline recommends prescription of one of the first line drugs, and then to, in addition to lifestyle, and to reassess them within 1 month. And if blood pressure control is met, if the goal is met, which is less than 130/80 in the next visit, to reassess them within 3 to 6 months. But if the goal wasn't met, to assess and optimize adherence and to continue assessing them every 1 month. For stage 2 hypertension, which was defined greater or equal to 140/90, the guideline recommends straight pharmacologic treatment in addition to lifestyle. In fact, as shown in the footnote, the guideline also recommends prescription of 2 first-line antihypertensive drug class if blood pressure was greater or equal to 20/10 above the target. The target was 130/80 or lower. So what the guideline says is if a patient with stage 2 hypertension has a blood pressure of 150/90 and above, it recommends prescription of 2 first-line drug classes. And we're trying to see how provider strictly follows those guidelines and how that relates to future patient blood pressure control. So in order, getting back into the development of the tool, we used a 5-step process to be able to develop and validate the measurement tool. In step 1, the investigative team read the 2017 guidelines, and we try to pick items or statements that we think are appropriate to assess provider adherence to the guideline. And we identified 31 items across 5 domains, focusing on screening, lifestyle, drug therapy, follow-up, and laboratory. And then in step 2, we assembled a group of 6 clinicians who are expert in hypertension management to review and score each item on how well they match to the guideline on a scale of 1 to 4. 1 from not matching, 2 match somewhat, 3 match, and number 4 match very well. And very soon we learned during this scoring method, our panel were not only assessing or scoring the match of the item to the guideline, but how important that item was, which was making a little of a problem, because the focus of this project was whether or not a provider adhere to the guidelines. So our items were whether or not that item matched to the guideline. So we ended up developing 2 scoring, 1 for match and the other for importance. I'll show you the results. Similar to the one for scale, we also asked whether they think that item is important to them for the management of hypertension as well. So the panel, after making the score, subsequently met face-to-face and reach a consensus on items that received a score of less than 3, either 1 or 2, from any of the reviewers. So the 31, if any of the 31 items received a score of 1 or 2 by any one of the 6 clinicians, that item was discussed during our face-to-face meeting. And using the information and feedback received in step 2, we refined the items and subsequently modified them, and we send again the items to rescore the match and importance on a scale of 1 to 4 in step 4, which is expert reevaluation. And in step 5, we calculated item content validity index as the proportion of experts who gave a score of 3 and above for an item, and scale content validity index as the proportion of items out of all the items that received on average score of greater or equal to 3. And in the literature, it suggests that item content validity index or score content validity index of 80% and above is considered acceptable. So those are the people who were involved as the expert panel for the evaluation and validation of the tool. As you can see, there was diverse expertise from primary medicine, internal medicine, nephrology, hypertension, pharmacology, and clinical pharmacology as well. And they've been very helpful, and somehow, directly or indirectly, some of them were actually involved in the development of the 2017 guideline as well. So out of the 31 items that the investigative team identified from the guideline, 12 items received a score of 1 or 2 by at least one of the panel members. And those are the 12 items that we discussed extensively during the face-to-face meeting. And 9 of those 12 items were modified after the panel discussion. 2 items were eliminated for lack of clear guideline support. We include them, but the team, the panel, felt that there was no clear guideline on the 2 items, so they were removed. And 1 item continued receiving item content validity index of less than 80 despite being rescored, and that was also excluded. So finally, we had 28 items with item content validity index showing 80% or above. 10 of the items received a score of 80% and 18 score of 100, This gave us scale content value index of 92.8. And the final item included 3 for screening, 1 for lifestyle, 17 for drug therapy, 1 for lab, and 6 for follow-up. I'll try to show you some of the items, not all the 28s, but I will show you some of the items that we included in the final tool. So this drug therapy related items out of the 17, remember in the previous slide I showed you we had 17 drug related therapy. I'm showing you here 6 that I think are important, which I will show you results today as well. So number 1 was whether patients with stage 1 hypertension, and if they have any atherosclerotic cardiovascular events or atherosclerotic cardiovascular risk of greater than 10% are treated with at least 1 drug. Item validity index for that was 80%, and then importance was 80%. And then patient with stage 2 hypertension with blood pressure greater or equal to 20 over 10 millimeter above the target. In other words, blood pressure of 150 over 90 and above. If this received 2 different first-line antihypertensive drug classes, 100% of the panel felt this matched the guideline. However, importance was only 60%. 40% of them thought that that is not important to follow as recommended. The other guidelines are, for example, patients with CKD and albuminuria if they were given ACE or ARB as first-line drug class, but if they have stage 1, 2 CKD without albuminuria, whether they've received any of the first-line antihypertensive drug classes. The other item we had was if patient with ischemic heart disease and no stable angina or previous MI received GDMT, beta blocker, or AC or IRB as first-line drug, and additional drugs as needed. So we're trying to see if some of those were followed as recommended. The other items focuses on follow-up as follows. For patients with stage 1 hypertension and ASCVD score less than 10 or with no coronary artery disease, diabetes, or CKD, the guideline recommends a follow-up within 3 to 6 months, and we try to see if that strictly was followed. And the match of that item was 100%, and they think all of them also think it was important as well. For stage 1 or 2 patients on blood pressure medication, the guideline recommends their first follow-up to be within 1 month, and their second and subsequent follow-up to be within 3 to 6 months if previous blood pressure control was achieved. But if previous blood pressure control was not achieved, the guideline says the second and subsequent follow-up to occur within 1 month, and we try to see that as well. And the guideline further says if hypertension is uncontrolled for 1 month within 2 visits, actually if properly followed, to increase medication dose or change or add a medication class and recommend adherence to the guideline. We try to see if there was any intensification from increase in the dose, addition of drug class, or change of drug class as well. And then we had lifestyle related items, laboratory related items as well as shown in here. So this is the design we had for AIMS 2 and 3. To remind you, AIM 2 was simply trying to see using the developed and validated tool to assess provider level of adherence to the guideline, and AIM 3 was to see the association between provider level of adherence to the guideline and prospective patient blood pressure control. Our study goes from January 2018 to December 2021, but we tried to see data back up to January 2010 to be able to identify any previous history of hypertension or taking any hypertensive medication, because we were interested in identifying newly diagnosed hypertensive individuals. So our eligible patients were newly diagnosed hypertensive individuals who are active primary care patients, which we defined having at least 2 documented visits per year between 2018 to 2021. And of course, age 18 and above, because that's for this group that the guideline was developed. And during that whole time period from 2010 to 2021, we also tried to identify different comorbid conditions from diabetes, coronary artery disease, heart failure, stroke, all the different chronic diseases that the guideline identified as important, requiring modification in the treatment. For example, in some of the previous slide, I showed you patient with CKD and with albuminuria greater than 300. It was the recommendation is to give AC or IRB. So we were trying to see if there were any of the following conditions, not only during our study time period, but up to 2010, in order for us to be able to see whether the first line of drug was prescribed as recommended. So at the same time, during the study time, 2018 to 2021, we collected extensively all available blood pressure control in the Vanderbilt Medical Center clinical data repository, all their prescribed medication, all the follow-up, specifically prescription medication for hypertension, or their follow-up laboratory result and provider notes. And we were trying to map that information to the tool that we developed in a way that would allow us to assess whether the medication was prescribed appropriately after the blood pressure increase, or whether the right medication was prescribed for a patient with stage 1 or stage 2 hypertension that have certain comorbid condition. And we try to see whether appropriate follow-up was also followed, whether follow-up was within 1 month if previous blood pressure was uncontrolled, or whether follow-up was within 3 to 6 months if previous blood pressure was controlled. So the data was scrutinized against the validated items that I showed you to assess concordance to the guideline. And we try to emulate target trial. If on the left side, I'm showing you how this would be done in a hypothetical randomized control trial, and how we try to mimic that in our study, or how we try to emulate that using the EHR from routine care data. So eligibility was newly diagnosed hypertension, no prior diagnosis or treatment, and greater than 2 elevated blood pressure visits within 3 months. So depending on stage 1 or stage 2, 1 reading was not enough. So we decided to see if there was 2 readings of high blood pressure within 3 months. In addition to the ICD code, being an adult greater than 18 years, and then greater than 2 outpatient visits per year, because some patients may come and disappear. It will be difficult to see adherence of treatment in those patients. So we restrict those that have at least 2 outpatient visits per year. So more or less, the eligibility is very similar to what we would do in target trial emulation. Treatment strategy would be guideline-directed hypertension treatment versus not. So, for example, 1 drug for high-risk stage 1, or at least 2 first-line drug classes for stage 2 hypertension with blood pressure greater than 150/90, and dose intensification or medication change when blood pressure control is not achieved within 1 month. Very similar to what you would do in target trial. But what we do in our study is to actually see the actual medication prescribed at each outpatient visit, and then to see whether that was there was 1 medication for stage 1, 2 medication for stage 2 with blood pressure of 150/90 and above, or whether there was an intensification in medication when blood pressure uncontrolled for at least 1 month. In randomized trial hypothetical, it would be to randomize to guideline concordant versus non-concordant treatment strategy. But in our emulation, it would be just to observe clinician prescribing pattern as documented in the EHR, which is non-randomized. Baseline index date would depend on what the objective is. For example, I'm showing in this slide the baseline that we had used for AM3, which was the association between provider adherence to the guideline and blood pressure control. So the baseline in a hypothetical RCT would be first hypertension-related treatment once eligibility are met, not necessarily the date of randomization once eligibility is met. And in our emulated study, the baseline will be the first outpatient treatment with confirmed hypertension after eligibility is met. So we try to see once that treatment was confirmed how whether that treatment was done according to the guideline versus not relate to subsequent blood pressure control of patients. Follow-up for a hypothetical RCT and our emulated design would be very the same. From study baseline, it goes all the way from up to administrative study in the lost follow-up orders. So in our case, administrative study ended December 31, 2020, December 31st, 2021, or last documented clinical encounter we had in the AHR orders. For outcome, we had two type of outcome, process outcome or clinical outcome. The process outcome focused on guideline concordant hypertension treatment, or specifically medication, guideline concordant follow-up, or whether the follow-up was done according to the guideline versus not, and guideline concordant hypertension intensification. Similar to that, the target trial emulation would be the observed guideline concordant hypertension treatment or follow-up as well as intensification. And our clinical outcome was blood pressure control status. In RCT, the analysis simply primary would be intention to treat, secondary per protocol, and because of the RCT nature, any marginal population average would be good. But in our case, per protocol analysis was our primary because we look at the actual observed treatment as it happened in the EHR. And our analysis included inverse probability weighting marginal structural model, which was proposed by Robin and Hernan. And in fact, this was helpful method of analysis in our situation because blood pressure treatment and control changed consecutively over time. So there was a lot of time varying confounding, which this method of analysis was helpful in our case. So the statistical analysis we used was inverse probability weighted marginal structural model. Why this method? Because medication use and blood pressure change over time. Past blood pressure and past treatment influence future treatment decisions. So treatment at visit 1 could affect blood pressure at visit 2, and in turn, blood pressure at visit 2 could affect treatment at visit 2 as well. So the IBW-MSP creates a pseudo population where treatment at each visit becomes independent of the prior covariates. This method of analysis is done by estimating probability of receiving antihypertensive treatment, similar to what we do in inverse probability. You calculate probability of receiving antihypertensive treatment at time t given prior covariates or covariates at the same time or baseline. And two models are calculated, the denominator and numerator model for the propensity score. And the weights are, stabilized weights are created by taking, by dividing the numerator probability by the denominator probability. I'll try to show you the formulas in the next slide. Then finally, you fit the marginal structural model by including the weights. And because there are multiple visits per patient, you include cluster ID to account for within percent correlation of the repeated visits. So this is what the denominator model looks like. Probability of A equals 1, which is treatment equals 1, given LT is the covariates, prior covariates at visit T. And similarly, first the model calculates probability of receiving treatment given covariates, and then for each patient, depending on the actual treatment they received, it calculates probability of receiving treatment given covariates, or for those who receives actual treatment, and for those who did not receive treatment, probability of not receiving treatment given covariates. And it's during this denominator model creation that it's important to assess the need for interaction terms, nonlinear terms, as well, using log likelihood ratio or wall test to see if they are really needed to be included in that model, because those interactive terms or nonlinear terms could improve accuracy of the model, and any misspecification during this procedure could result biased weights creation and ultimately biasing the MSM model. The numerator model is simply prevalence of the treatment in the sample without adjusting for the prior covariates. Then you create the stabilized weights by dividing the numerator by the denominator. You include those weights in the weighted pooled logistic regression in our case. So I'm going to show you results uh, for some of the items that I think are important. So remember the guideline for stage 1 hypertension with comorbid conditions such as diabetes, CKD, or coronary artery disease, or atherosclerotic cardiovascular risk greater than 10%. It says prescription of one drug, which is shown in these red boxes. We tried to see if that was strictly followed versus not. In fact, the guideline, the evidence to support that particular item or that particular guideline came from sprint trial, the Accord diabetes, different meta-analysis, such as the diabetes RCT meta-analysis, stroke meta-analysis, and CKD meta-analysis. And those studies have showed that reducing the blood pressure lower than 120, systolic lower than 120 compared to only less than 140 in the sprint, for example, decreased cardiovascular composite outcome by 25%. In the Accord trial, it shows reduction in absolute stroke by 1.1%. And then the meta-analysis also showed reduction in cardiovascular events, stroke, albuminuria. All of them are supporting the greater reduction in blood pressure and better cardiovascular outcomes, which led to the development of this particular guideline. So what we did was we calculate the proportion of visits with stage 1 hypertension. We call that treatment opportunity, that were followed with a prescription of at least one first-line antihypertensive medication class within a month. So what we did was we tried to identify treatment opportunities. Those were blood pressure values that are 130/80 and above, systolic between 130 to 139, diastolic between 80 to 89, because that's the stage 1 hypertension. But of course, we restricted that to those individuals that have CKD, diabetes, coronary artery disease, or their ASCVD risk score greater than 10%. And we try to see if those patients received at least one of the first-line antihypertensive drug class within 1 month. And then how that relates to, or how that correlates with the next blood pressure control, which is measured sometime between 1 week to 6 months. We try to give 1 week for the medication effect, for the medication to take its effect, and we go up to 6 months because sometimes patients receive medication for up to 6 months, 3 to 6 months. And so we try to see whether that treatment according to the guideline versus not led to improved blood pressure control. But during this time, we had individuals, for example, for a patient with stage 1 hypertension, that patient may not necessarily receive treatment within 30 days, but could receive a treatment after 30 days. And it's possible that their subsequent blood pressure could be after that treatment which occurred more than 30 days. So we identified those individuals and we censored them because the treatment happened after 30 days, which obviously could subsequently affect the blood pressure if the blood pressure, their next blood pressure control measurement happens after that particular treatment. So we create an indicator of censoring for those individuals, and we created not only treatment weight, but also censoring weight in our marginal structural model analysis. So this is our results. Among those stage 1 hypertension with comorbid conditions or ASCVD risk score greater than 10%, only 21% of them received treatment according to the guideline, meaning there was prescription of one first-line antihypertensive drug class. Close to 80% of them did not receive. This is very low result. I tried to see even the trend over time, and yes, there was an increase over time from 2018 up to 2021 gradually, but still it's in the low end, less than a quarter. I tried to even see if that varies by diabetic patient, CKD patient, and patient with ASCVD events. Very similar, 21% in diabetic patients, a little higher, 28% in CKD, and 27% in those with clinical ASCVD. And this slide is showing the association between receiving treatment in stage 1 hypertension according to the guideline and subsequent blood pressure control. Model 1 with few adjustment, model 2 further adjusting other covariates. And in the fully adjusted model, we had seen the odds of blood pressure control increased by 13% among those who received treatment according to the guideline versus not. Similar pattern for the systolic blood pressure. There was 2.02 millimeter of mercury reduction in systolic blood pressure in the fully adjusted model if they were treated according to the guideline versus not. Of course, systolic blood pressure of 2 seems to be very small, but population-based study showed that even as 2 or 3 millimeter of mercury reduction in blood pressure is related to about 5 to 10% reduction in cardiovascular events. I'm going to show you result for the stage 2 hypertension in here. The guideline says patient with stage 2 hypertension to receive at least 2 different first-line antihypertensive drug classes if their average blood pressure was greater than 20/10 above the target. The target was 130/80, so more or less if the average was greater than 150/90, as shown in the red box. And we tried to see if that was strictly followed. The literature that supported the development of this guideline or this particular item was the study by Wald and Wang that showed 2 different drug class versus 1 class. So in this, they have shown single drug class reduced by 7.3, 6.8, or 8.4, but more or less when 2 drug combination were used, the reduction in blood pressure doubled by 14, around 14 to 18 millimeter of mercury. And similar, the Wang study compared monotherapy treat for drug combination versus monotherapy or usual care, and they have showed a better reduction in systolic blood pressure and better reduction in blood pressure control, 66% versus 46%. So more or less, what this is telling is that 2 different drug classes are better at reducing blood pressure or improving blood pressure control better than usual care or 1 drug as expected. But we're trying to see how strictly that was followed. In fact, of course, following treatment treatment according to the guideline is expected to improve blood pressure, of course. And that was not even the main motive of this study. The main motive of this study, as I mentioned it earlier in the previous slides, was to see if the decline we were seeing in the blood pressure trend back then was really quality of treatment, because there was a suggestion that treatment quality was a driving force back then. So after adjusting all those other risk factors, was there really an association between quality of treatment and blood pressure control rate, and to see whether or not providers strictly follow the guidelines. So for the stage 2 item, similarly, we identified treatment opportunity. In this case, blood pressure readings of 150/90 and above, and if there was prescription of a medication, at least 2 first-line medication within 30 days of that. If a patient has medication even prior to that opportunity, that was considered as receive 2 different drug class as well. Or that prescription could happen within 1 month of the treatment opportunity. And then we try to see how that associate with next blood pressure control within 7 to 183 days. And of course, during that time, we try to censor individuals who receive treatment after 30 days, but before their next blood pressure control, and include censoring weights in our final analysis as well. So this is the result. In those patients, stage 2 with blood pressure of 150/90 and above, only 26% of them were treated according to the guideline, meaning received 2 first-line antihypertensive drug class. The other 74% did not. And try to see this pattern over time. Of course, there was gradual increase over time as well. Yes, it takes some time for providers to get used to the guideline. And remember, this was done during the COVID time as well, which might have affected our results, but there was gradual increase in the treatment according to the guideline over time, as shown in the second graph. And the lower graphs are showing the association of receiving treatment according to the guideline with blood pressure control. In model one is showing at least two different first-line drug class versus not. The not people in here could include those who received one drug class, by the way. So if you analyze it this way, you see the odds of blood pressure control increased by 45% for those who received treatment according to the guideline versus not. But in model two, which is the orange line, compare receiving at least two different drug class versus one drug class, we didn't see any significant association between that and blood pressure control. Similar pattern for systolic blood pressure and diastolic blood pressure. Comparing two first-line drug class versus not resulted in reduction in systolic blood pressure by a mean of 3.79 millimeter of mercury and diastolic by a mean of 1.93, but not significant association when comparing at least two different first-line drug versus one first-line drug class after adjusting those covariates. I even try to see how, let's take the reference group, the untreated, and compare those who were treated but not according to the guideline and those treated according to the guideline. So for the blood pressure control, for example, using the untreated as a reference, there was the odds of blood pressure control was increasing by around 10% among those treated but not according to the guideline, but not statistically significant. But if they were treated according to the guideline, with at least two first-line drug class, the odds of blood pressure control was increasing by about 48%, and similar pattern for the systolic and diastolic blood pressure. Now I will jump into whether follow-up recommendation were appropriately implemented by providers versus not, and how that correlate with blood pressure control. So the guideline says if previous blood pressure was met, the previous blood pressure goal was met, which is less than 130/80, subsequent blood pressure visit to be within 3-6 months. But if blood pressure goal was not met priorly, the next visit to be within 1 month. And those are the results. So we calculated proportion of visits with stage 1 hypertension or stage 2 hypertension that are second or subsequent follow-up visit within 1 month if the last blood pressure goal was not met. And we observed only 37% of visits were appropriately followed within 1 month if the prior visit blood pressure goal was not met. And trying to see the association of that with blood pressure control in the fully adjusted model, we have seen blood pressure control odds increased by 34% if the follow-up visit was appropriately followed according to what the guideline says, and similar result for the systolic and diastolic, all of them significant association. Reduction by about 2 millimeter of mercury for systolic and 1.5 for diastolic, if follow-up was done according to the guideline versus not. And this slide is showing very similar result, but if the follow-up was done within 3 to 6 months, the guideline says if your prior blood pressure goal was achieved, the next visit to occur within 3 to 6 months. And we in fact saw a very high proportion of visits according to this recommended guideline, 81%, mainly because the time period was 3 to 6 months. So if your prior blood pressure was controlled, your subsequent follow-up visit to occur within 3 to 6 months, and 81% of the follow-up visits were done according to this guideline. However, there wasn't really association between that follow-up guideline and blood pressure control. There wasn't any difference between those who were followed up within 3 to 6 months versus not in terms of their subsequent blood pressure control, as shown in here, as well as no association with systolic and diastolic blood pressure outcomes. This slide is showing what proportion of providers increased medication dose or change or added a medication class when blood pressure control wasn't achieved within 1 month. The guideline says if blood pressure control goal is not achieved for 1 month, it recommends to increase medication dose or change or add a medication class. And similar to other studies that I have showed in way at the beginning of my presentation, we have seen only 42% of providers treated according to the guideline in this situation, meaning when they observed blood pressure goal not achieved for 1 month, only 42% of the providers increased dose, medication, or add another drug class, whereas close to 58% were not. And how that relates to blood pressure control, as expected, even in the fully adjusted model, the odds of blood pressure control increased by 7%. So it looks small, 7% compared to the previous that I was showing you. But remember, those are group of individuals that are hard to treat or hard to have their blood pressure controlled, but no significant association, a similar pattern for systolic and diastolic as well. So some of the strengths of these studies that we used, we think we used a validated measurement tool because we involved a panel of 6 clinical experts who has helped in the validation process, as I have showed previously. And by directly observing provider practice, even though it's from their EHR record, we think we reduced recall and social desirability bias. And our longitudinal follow-up, large sample size, helped us to assess trend over time and see temporal sequencing as well. And we think this study is scalable and reproducible across institutions and across regions because of the validated tool we have. For the sake of transparency, the results that I just showed you hasn't taken into account side effect or contraindication yet because I haven't completed that analysis. But this study will also take into account side effect or contraindications, which is unique compared to previous study, because for a valid reason, a provider could deviate from the guideline whenever there are drug side effect or contraindication. However, some of the limitation is data fragmentation across healthcare. If there was fragmentation, we would lose that part, and this would cause some misclassification in our result. Of course, any EHR will have measurement error or missing data, which could bring misclassification in our medication record or blood pressure record. And of course, residual confounding is also another issue, because specifically lifestyle factors are difficult to capture in the EHR, although we try to include smoking, BMI, alcohol intake, we didn't include exercise, and those variables were very hard to capture in the EHR. So despite our propensity score, we think there is some residual confounding. And potential misclassification of provider adherence is also another issue, because a provider may suggest prescription, but a patient may refuse, and at that point, we wouldn't see any prescription from a provider, which would put that provider or misclassify that provider as being non-adherent. And because we included individuals who have at least 2 visits per year, who have access to a healthcare system, our study underrepresents individuals with limited access to healthcare or being or uninsured or underinsured. And the fact that this study was done during the COVID time, there was care disruption, which we expect to see a higher degree of adherence in subsequent study. And currently we are having our R01 study on this that we think would see a better level of adherence. So the conclusion is we have seen lower adherence to recommended medication selection or titration, specifically between 21 to 26% for medication selection and 40% for medication intensification. Mixed finding for recommended follow-up. If the follow-up is to be within 1 month, only 37% were done according to the guideline. But if the follow-up was from 3 to 6 months, most of the follow-up were appropriately done, up to 81%. And adherence to the guideline based prescribing and titrating, as well as recommended follow-up, consistently showed improved odds of blood pressure control, as I have shown in the slides. And among treated patients, though, prescribing two first-line drug versus one, we haven't seen any association in that. That didn't lead to improved blood pressure control. So future directions are, we have seen only about 21 to 26% of providers prescribing medication appropriately as recommended in the guideline. Why providers deviate from the guideline is an important thing to study. And we've seen disparity in blood pressure control by race, ethnicity consistently even among individuals who are treated. Could this be also due to lack of appropriate treatment according to the guideline? So for those 2 points, we subsequently submitted RO1. We ended up getting the RO1. I'm the primary PI for that one. It's in its second year. And I think the other thing that is important to study is long-term effectiveness and safety, because providers, we have seen up to 70-80% of providers were not following the guideline, mainly because they were concerned of long-term safety outcomes such as acute kidney injury, electrolyte imbalance, fall, and syncope. So it's important to see also proportion of MACE or safety outcomes comparing guideline adherent versus not. Although not funded, we had submitted a grant focusing on that as well. So the persistence of uncontrolled blood pressure among treated individuals with access to care and health insurance, despite availability of effective treatment, likely reflects its inadequate implementation of guideline-directed care rather than lack of medication efficacy that's leading to poor blood pressure control. And this underscores the need to understand the determinants of deviation from the guideline and developing implementation-focused intervention. I think what's needed is implementation-focused intervention, because we have very effective medications that work, could improve blood pressure up to 90%, in fact. Thank you. That's all my presentation. Happy to hear questions, suggestions.